Good morning, everybody. Dr. Gabriel Jasper, MD, interventional pain physician with Jeremy Vickers.
That's right.
All right, we're going to talk about today. The topic would be the new stuff because it's been a while since I've been on. Can you hear me pretty good?
Perfect.
Yeah, it's been a while since I've been on, and I'm not on consistently every week. So all of a sudden, all this stuff starts creeping up that's coming out of the system
Yeah.
that we're doing, and we're honing in on how to get rid of every little pain generator. Every year that goes by, something new comes. Maybe two or three new things come up.
Right.
You got people down there, scientists, just people inventing and discovering ways of getting rid of pain. And it works. I get so many people coming in and showing me this new stuff. And half the stuff isn't good, but the stuff that's good gets rid of the pain.
That's great.
And I'm always skeptical about new stuff. But once you see it working, it's amazing on the discoveries and the inventions that come out today.
Mm.
Well, just to let you know what I do, if there's any new people listening to me, what I do is I do interventional pain, which means that I get rid of the pain generator. I find it, and that's what we're discussing today, how we can get rid of pain. I mean, people come back to my office in the old days, say, Doc, I'm like 10% better. Thank God you helped me a little bit, but I still got a lot of pain. And I said, well, this is all you're going to do. Your choice is either surgery, which is probably not going to help you, or just live with it. But today, people come back, Doc, I'm like 90% better. Can you get rid of that 10%? Guess what? Most of the time we could because of the new stuff. Most of the time we could because of the new stuff that's coming out. And we can get rid of that little bit of 10% pain that we were never able to get rid of before. So it's possible we can get you virtually pain-free. Even the old timers, the older people that have all this different pain. Anyway, I do your traditional stuff. I'm an interventional pain physician. I've done my surgical residencies, residency anesthesia. I'm fully trained in pain and board certified in anesthesiology. I graduated a million years ago where they really didn't even have fellowship training. So I'm not fellowship trained. Why? Because I think there was one or two in the country, and they weren't learning anything more than we knew from our residency in anesthesia. Because we knew it within a year in those days, you knew everything we possibly could know. It wasn't that much, but I knew the evolution is coming, and it's coming, it's here, and it's keeps evolving every day. But anyway, so I do your typical epidurals. Why? Because sometimes someone gets in it. By the way, somebody has back pain, leg pain, 80% of the people goes away on its own, right? But sometimes you got to intervene with some kind of procedure. Like, for example, one of the most basic ones we do is an epidural. And 80% of those people get better. But then you get the percentage of people where it just doesn't get better, and then you go to the next step, and the next step. And you gradually go up to the next step. And I've managed to keep people out of pain for a long time, and I've managed to keep people out of major spine surgery for a long time. In fact, when I say a long time, not an individual person for a long time. I'm talking about I have been able to do it. I've been doing it for a long time.
Right.
Years that I don't send people for, especially lumbar spine surgery. Cervical, I tell you what, even the cervical spine surgeries are doing pretty good today because those are evolving and the surgeons are following it.
Yeah.
But you got so many people doing lumbar major spine surgery that
big open back
that should have been obsolete years ago.
Yeah.
And I hate to say it. People question me. What do you mean it's obsolete? Well, it is, and I'll continue to insist on that.
I actually spoke with a patient, and she was telling me that what was I saying? I just spilt everything. She was telling me that she was afraid of big open back surgery, and I showed her my scar when I had it, and then I showed her the little tiny dot that you left behind, and she felt a lot better.
Really?
Because of it. I got to mop this up.
What'd you spill? Anyway, we can go back to me maybe.
Yeah, there you go.
Here we go. So, like I said, we do the basics and we move our way up to something that is not invasive. None of it's invasive that I do. Some of the, it seems like the new procedures are quicker and easier and more efficient. And that's the name of the game with anything. Even cars, motorcycles, airplanes, everything gets more efficient, easier, safer, right? But I want to talk about a few things. We got different parts of the body. Where'd my model scope? Oh, give me those models. We got different parts of the body, well, the spine in itself, that we can fix. For example, we have this is the vertebral body here, right? Everybody's used to having sciatica pain, right? Everybody's used, not used to it, but everybody knows what sciatica pain is. Sciatica pain is when you got a pinched nerve, and spinal stenosis. We've been treating that for years with epidurals. Sometimes it works, sometimes it doesn't. It doesn't. We go to the next step. So that's so you can see this.
Yeah.
But we've evolved. I mean, sciatica pain is really an inflammation of that nerve root right there.
Right.
Right. And when you have inflammation, there's ways of getting rid of that inflammation, which we've been doing for years. But now we noticed, and then we figured out that these joints back here, right here, these joints that move in the back here, see?
Yeah.
These joints.
Mm-hmm.
Those joints are called spondylosis, inflammation of the facet joints. I've been doing procedures for that for over 20 years that work. So we get rid of the arthritis pain easily. We get rid of the sciatica pain easy. Then now we've known that people have had pain in their disc, right? In their disc. This is the disc right here, right? Guess what they call that? Discogenic pain.
Makes sense.
And I had a patient the other day say, "Listen, I never went to the discotheques. I'm too old for that." I said, "Well, it has nothing to do with going to the disco.
Yeah. Disco is not dead,
but it's discogenic pain because it's the disc."
Right.
We have things for that, which I'm going to tell you. If you have pain in this vertebral body, right, for certain reasons, it's called modic changes. That's called vertebrogenic pain, right?
Right.
And we have treatments for that. We also now have discovered, and I've been saying this for years, just like with the discogenic pain, I've noticed that people have certain things that you see on the MRI, and when you see it on the MRI, a lot of times, I'm starting to get seasick here.
Sorry, there you
go. A lot of times when you have patients that come in with MRIs, and you see these different phenomenal, pathological lesions, I can call it,
right,
on the spine, and they got a name for it, like modic changes. Modic changes, for years, I've been looking at those things and saying, I get rid of all the pain, but people still have pain in their back. I bet you it's from those modic changes. And we talked about them. I always bring it up at the conferences for years. I've been doing this for so long. And they're like, no, it's just, there's no pain. Well, guess what? Some guy figured out, did a process of elimination, and they figured out how to treat it. And you can get rid of the pain with that now. And I've been doing that now for a year or two. And we've talked about that. And the way modic changes are, see, this disc right here is probably 1/4 the size it's supposed to be. So the discs break down. And listen, anything breaks down, you're going to get a certain amount of inflammation. And it breaks down into the bone itself. And then you can see these white patches right on top of the disc and below the disc. They call them modic changes. When a person has that with certain types of pain, like leaning over, leaning back, well, most of the time just consistent low back pain, nothing else gets rid of it. What I do is I noticed what they discovered was there's a nerve in the center of this, and here's it looks like a spider, spider web type nerve, and the center is the nucleus of that nerve. And we come in through this bone here and go into the center, right? And we heat it up. And we heat it up at a certain temperature for a certain amount of time, and it completely stops that nerve from working. It's an ablation of that nerve. We do the same thing with the arthritis. It's called radio frequency ablation, and you heat that up, and these nerves, as you could see, go from the bottom to the top,
Mm.
and they here it is from the bottom to the top, and they all that these nerves here, these ends of these nerves bring pain sensation to your brain. You burn the nerve, it doesn't work anymore. You don't feel the pain from that, and it works tremendously well. And like I said, I was skeptical.
Mm.
I did a few patients, and the pain went away.
Right.
But it's not something you walk into an office and you see that and you treat it, because most of the patients that come into your office, they're not complaining of that kind of pain. In order to get to that kind of pain, you got a lot of other things happen. You get the degenerative disc disease, which causes sciatica pain, causes central canal stenosis, causes the arthritis. Most of these things are done first, right? And but then there's a relatively new, and I talked about this too, and I like to talk about the new stuff because people think that you get an epidural, it doesn't work, you go get major spine surgery. No, you come in and we do the epidurals, and I'll get rid of the pain from that from whatever's causing the pain from that you get rid of with the epidurals goes away. Not all the time, but we know we can tell the difference once we know that pain is gone, which is difficult, takes time, takes experience to realize that you've gotten rid of that pain. And then now you go to the next thing before you think of any kind of surgery.
Yeah.
And people get what they call discogenic pain. What is discogenic pain? This part in the middle here, which is called the nucleus, which has ruptured and has causing a herniated disc.
So the nucleus ruptures and bulges right out, and it's actually part of the nucleus that's pressing against the nerve.
Yeah,
That's interesting.
that's the sciatica type pain.
Right.
But we're not talking about that right now. We're talking, forget about this herniation. Look at that red part in the center. That's the nucleus. And the nucleus is exactly what it says. What it is. It's like the heart of the disc. It's that part and the annulus, which goes around it. And what does annulus mean? It goes around, it's a ring. Annulus means in Latin, it means ring around the nucleus, right? So they start to break down, but usually the core is the nucleus. That starts to break down, then everything else breaks down, right? So you gotta know how to treat it.
Yeah.
And listen, we proved years ago by doing discographies that by doing a discography, you can prove the person has discogenic pain. But certain types of maneuvers, for example, bending over, lifting things up, sometimes coughing, sneezing, but sitting down too long and you get pain, that's a characteristic symptom. But most of the time, it's pain just about any time coming from the disc. Any pressure on it is going to hurt. Usually lean forward, puts pressure on it. Now, it's not that pain that you have when you walk, intermittent claudication, which means you walk a certain distance and you got to sit down and the pain goes away. That's spinal stenosis.
Right.
And we usually treat that before we treat this, because you're not going to feel the benefits from that unless you treat the spinal stenosis. But I get a company, I find out about a company that replaces this nucleus, completely replaces it. And I'm like, that's weird.
Yeah.
Everybody's talking about, hey, listen, doc, what do you think? Should I go for a disc replacement? And they replace the whole disc with artificial discs, artificial. And basically they plump it up. Now, I'm sure there's studies out there that say it's successful, but I'm sure there's tons of studies out there saying it's not successful and it hasn't been mastered yet. Who knows? But what I do is I found out about this company down in Florida. I went down there and we talked about it again. Down in Florida, it's a 100,000 square foot place that people, when they donate their body to science, anywhere from like 14 to 35, they retrieve these perfect nuclei. Perfect. They harvest it and they process it down to a powdered form. They send it to me. I take a needle and I put it in the middle. I reinstill it with some normal saline. I put it in the middle and I fill it up. And it actually, it's like equivalent, I could say, to a heart transplant.
Right.
Person has a bad heart, you get a new heart. Now you got a good heart. You got a bad nucleus, you put that in. Now you got a good nucleus. And they say it stops degenerative disc disease dead in its track. That's what the talk is.
Yeah.
I don't think it stops it dead in its track. But ladies like says to me the other day, well, how? What do you mean it stops it? So I come up with my own ideas how to rationale why people would say it stops it. I would say it probably slows it down, or now you got a new lease on life, new lease on a disc,
Right.
or a new lease on your nucleus, right? And the patient says, "Well, how does that work?" So I said, "Listen, how old are you? 80 years old. All right, it took you 80 years old to get degenerative disc disease and a bad nucleus. So I put a new one in there, common sense. Now this is all just my own
Yeah,
rationale.
yeah,
This is
yeah.
nothing scientific or anything like that. But when they say it really stops it, it stops it because it took you 80 years to get it to break down. It'll probably take another 80 years.
Yeah.
That'll make you 160 years old. So guess what? It stops it dead in its track. You'll be dead way longer before it's going to start to bother you. And people been coming back. Everybody's come back feeling better. Feeling better. Unless you skipped over a pain generator that you didn't treat, because this is usually one of the last things I do. And that's why they do so well, because usually the last pain that they have is a pain from their discogenic pain.
But like you said, if you skip over the spinal stenosis procedure and go right into this, it's not gonna. It may not help you
It's
as
true,
quickly.
because I had a patient recently that I did I think a 2-level spacer for the spinal stenosis, which that's what works the best for spinal stenosis. It opens up the spine. And they had another one that was very mild. It wasn't really that bad. So I was kind of reluctant to put another spacer in it, but they complained at that point, they complained just as much as walking pain as they did sitting down and bending over kind of pain.
Right.
So I said, you know what, maybe the walking pain isn't as bad as definitely not as bad as it was, because we fixed 2 levels and they were definitely improved. They said they're 80% improved, but they still can't walk as far as they want to. So I said, and they had it 90 days. I couldn't put another one in for 90 days. I said, you know what, let's do the via disc. Let's replace the nucleus, right? Replace all the bad ones and replace it. The guy came back about 20, with about maybe 20% better from that pain that we were treating. Overall, they were already 80%, but that pain that we were treating came back 20%. So I came to the conclusion that the patient, 20% of their pain was from the nucleus pain, the discogenic pain. And sure enough, finally bit the bullet. It's hard to do when they're not that bad. I put a spacer in after 90 days and the pain was gone. So you're not all going to get perfect with this.
Right.
Because like I say and I insist, that you can have multiple pain generators causing the same type of pain.
Yeah.
Because what's the same type of pain? Doc, I got back pain. Of course, you could usually figure out what kind of pain it is and isolate where the pain's coming from. For example, somebody gets up in the morning and they get up and they're like, oh man, and they move around and the pain gets better. That's usually arthritis.
Yeah.
You're not going to get that from spinal stenosis. I mean, some people are so bad with spinal stenosis, they stand up, boom. That's when they get up in the morning, they got pain.
Right.
But that's the kind of pain that doesn't go away. Like arthritic pain, it eases off as you walk, as you move around throughout the day. But if you sit down for a long time, like in your car or on a bench, or you come to Dr. Jasper's office, you got to wait for 2 hours.
Right.
And when you get up, it hurts.
Yeah.
Low back arthritis. That's one of the ways I make the diagnosis in my own doc. I was pretty good when I came here, but I sat there for 2 hours. When I got up, I got severe pain. I said, you got arthritis. I can fix that.
Well, the multiple pain generators, I was just thinking, imagine getting shot 2-3 times, right? But the surgeon only takes out 1 bullet. The rest of them, leaving them in ain't gonna help you much.
Well, that's why when you see spine surgery, you see, that's a good point you bring up, and we bring it up all the time. When you see spine surgery, surgeon doesn't want to operate multiple times. It's a big operation.
Yeah.
It makes sense. So what they do is they say, all right, you got a bad 3, 4, 4, 5, 5S1. They operate on all of those levels. And some surgeons have the means to isolate which one's the worst
Mm.
because they learn over the years how to do epidurals. When I do epidurals, I can isolate which level's the worst level. Sometimes you do an epidural on one level, they're 100% pain free. If you do it at the wrong level, in other words, one that looks bad but isn't causing most of the pain, they might get 50% better. So now you know that 50% of the pain's coming from there. So when the surgeon learns how to do these injections, and I'm not one of those doctors that say, that's anesthesia, that's pain, that's physiatry. We're supposed to be doing those. Send them to us, and we'll do. No. In order to be a good spine doctor, I think you got to know everything, and you got to know how to do everything. Me, I don't know how to do spinal fusion, and when I say spinal fusion, I'm talking about rods, screws, and rods.
Yeah.
I don't know how to do that. I'm not trained for that. I don't pretend to do that. I don't want to do that. And it's a very, very good surgery done at the right person who has instability of the spine. Really not for any other reason.
You had a what was it, an X-ray up on the wall for years. This old patient of ours, I think his name was Ralph, and it looked like he had 2 old style wrenches in his back. Like I was a little bit more
You see the new
archaic.
one on there?
No,
Well, it's on the wall right now. You look.
no,
on the
I didn't
wall?
see.
Well, when you get back, you look at it. The guy has a fusion from T12 all the way down to S1, and at the same time, rods and screws going to the sacroiliac joint.
Wow.
I don't know why would anybody would do that. And the guy said it didn't do, just made him worse.
Oh my God.
But
That's what you
I'm
call.
not here to bash a surgeon.
That's what you
doing
call
fusions.
failed back surgery syndrome. Right?
Yeah. But I'm not here to bash the surgeons.
No.
Today I'm here to how to avoid those kind of surgeries, and that's my goal in life. So now we talked about the new stuff. We talked about how to treat the disc, how to treat emotic changes in the vertebral body, so vertebral body and discogenic pain. Right now we talk about SI joint. We just talked about that patient that had like 6 levels plus the fusion of the sacroiliac joints, which I don't have one here, but it's overkill.
Yeah.
But
can you imagine that when we first started this show, many of these things didn't even exist then?
well, a lot of it didn't exist over a year ago.
Oh, well, yeah.
About a year and a half, a lot of these things.
But
Some stuff just coming out today, which I'm going to tell you about.
Yeah. But I've been recording so many testimonials from happy patients. It's ridiculous. If you guys want to see them, please go to our Facebook page for Jasper Spine Institute. And there's a whole bunch you can just check out and listen to these people and their happy stories.
I saw one today that Philip, I think 20 hours ago he did. I don't even remember.
Yeah.
And that was a testimonial about doing PRGF of his knees.
Yeah.
His knees or his hips. I think his knees. And it was like 3 years ago, and the guy was like, fantastic.
Oh, that's amazing.
But anyway, what was I saying? I was leading up to something. What was I talking about when you interrupted me?
I was flying off on a tangent.
Yeah, what was it? Well, anyway, what I was talking about was the 2 things we already talked about. And there was one thing, the SI joints. I was right in the middle talking about SI joints.
Sorry, doctor.
Now, SI joints, anybody has any SI joint pain, they know what an SI joint is. And I don't have the models here for visual aids, but the SI joint is the hips that go up, right? Hips that go up, and you got the V in the middle, which is the sacrum, and you got on top of the sacrum, you got all the spine, all the vertebral bodies in the spine above it. So it's a joint that is connected to all the hips, all the pelvis and the joint. A lot of people get SI joint pain. Who gets them? The most common people get are women. Why? If I had the model here, you could see that there's a hole on top, wide hole, which is where all your intestines and the inners are, and underneath is a hole where your genital are, where to go to the bathroom, and the vagina to have a baby. Right. So when a woman is close to delivering a baby, the hormones change and they loosen up the SI joint and they loosen up the symphysis pubic so that it can open up and expand to let the baby out. And then eventually it closes up. Hormones change and tightens them up. Especially if you got 2 or 3 or 4, 6 children, it opens up, expand. These people, for some reason, because of the fact it's open up, sometimes that joint, the 2 joints, start to loosen up and they're unstable to a certain point.
Mm.
And every time they move, it hurts. And then it creates an inflammatory process in the joint. And the joint is not like a smooth joint, like a hip joint or a knee joint. It's kind of a jagged joint that fits in like a puzzle.
Yeah.
So that all those grooves and concavities and concavities, they rub and they hurt. And I've been, for many years we've been giving SI joint injections, and they work most of the time, but not all the time. And what happens is these people, it doesn't work on is because it's just too unstable. So, like that person that had the SI joint put together with the 6-level fusion, probably had that same problem. So they figured they killed 2 birds with 1 stone, or 10 birds with 1 stone, but really doesn't work.
Right.
But if we could really isolate that they have pain in the SI joint, which I've been doing a bunch of them lately, then what we do is stick a little pin in. They call it SI joint fusion, but I hate to use the word fusion. It's kind of a scary name.
Yeah.
So all it is, they used to have to put 3 screws in. It went down to 2 screws. Now we got a company which puts 1 screw in, and most of the companies coming out with 1 screw, and the screws are designed that if you got a space this much, right, you kind of drill a little hole, you put the screw in, and once the screw bottoms out, you keep tightening it, and the joint gets squeezed together. It stays there, right, and that's it. I had a patient that came back. What was it? Yesterday. Came back yesterday, and I did it 1 week ago. Now you're talking about fusion, right?
Yeah.
Pinning. 1 week ago I did it. She says, I no longer have the pain that I had before. I could stand on it. I could walk. I don't have a little soreness because it's only been a week I did the procedure. It's more like a dull pain. It was a sharp pain every time she moved. So it worked. And they're going to get better and better. It's going to fuse and stay there. So that's another one that's relatively new. Is it new? It's not real new. But what's new is the way we do it.
Mm.
Minimally invasive or non-invasive. I'm talking the incision was this big.
Oh yeah, it's small.
Yeah, so there's really no incisional pain.
Yeah,
and there's no real pain from the procedural pain.
heals up like a freckle.
Yeah, I mean, it's ridiculous. It's
Yeah.
ridiculous.
Ridiculous.
how
I've
it
had
works.
many of them, and you could barely even see them on my back. That's how amazing these procedures
So the
are.
point is here: if you got not everybody's doing it this way. A lot of people are comfortable with the old way of doing it, with these 3 screws, 2 screws, posterior screws plus these screws. It's almost like major surgery. You don't need it. This is what I do. If you got if anybody diagnosed with you with SI joint, those SI joint injections are not working, I can fix that with a very simple, fast, not painless, but a lot less pain and faster recovery.
Yeah,
And that's what the key is.
that faster recovery is everything.
Yeah.
You can get right back to your life quicker.
Yeah. When we used to do them years ago, you had to have no weight bearing for a while. You couldn't stand up for a while. And you don't do that, then you create all kinds of other problems.
Yeah,
DVTs and, get out of shape, atrophy. Atrophy. Now we talk about atrophy. Is a relatively new, I've seen it probably for 5 years at these conferences. And people who have out of shape, never exercised, their muscles in their spine, core muscles, the core, talk about core strengthening type stuff.
yeah,
The core muscles, which one of the major one is a multifidus muscle. And the multifidus muscle you find along the spine, right? And it really keeps the spine with muscle tone. It keeps it straight, and it keeps it from moving. in abnormal ways, and when you're strong like that, you have less back pain or no back pain.
Right.
But I've noticed that. So, and when you look at the MRI, when you look at the back muscles in the MRI, it looks like a T-bone steak because that's what it is basically. You know, when they cut the T-bones from a beef from cattle, it's they're those muscles. And somebody with a very strong back, it's all dark and obviously hypertrophic.
Mm.
But then you get some of the people, it's white. It's totally white. They got no more muscle. And a lot of these people lean forward, not only because it helps them with spinal stenosis, but you have somebody lean forward because just lack of exercise, maybe spine surgery they had, whatever it is, and the muscles are so weak they can't stand up
They don't have
straight
the
for any period of
strength.
time
Yeah.
because they fatigue the muscles because there's only very few fibers.
Mhm.
Now, I saw this years ago, and I've been trying to get in touch with, I had a site out of mind. I got so much stuff going on, all new stuff,
Oh yeah.
but you couldn't find a rep. You call them up, they wouldn't follow. But guess what? The company now, because of the fact they proved that it really works, they come out. They're hiring new reps, and I got reps coming to my office, and they showed me the procedure. Of course, I saw it at the last convention. But what it is, what do you do? How do you get better? How do you get better with that? You work out. You go to the gym. You go to physical therapy. Intense. But somebody who's like 70, 80 years old,
Yeah.
even some of the younger people, you know how much you got to go to the gym to work out, to build those muscles up? It's almost impossible. You got to go 5 days a week, and you got to do some intense workouts.
It's a lot.
The joints
Yeah.
sometimes can't even tolerate that, and then they're at risk of hurting themselves. What they have is these special wires that go up through the muscle, right? And they lay them right on these transverse process because you got the nerves there. Those are the nerves that we ablate because they're sensory nerves and they're motor nerves. The major function is sensory and plus motor
Mm.
for the metaphysis muscle, right? If I stimulate that, the muscle contracts, right? So they've done studies on this, and they've done studies, and they have it FDA approved now of the way they treat it is maybe take 10, 15 minutes. You put these wires with electrodes on it right over that nerve, right? And you stimulate the nerve, right? And it contracts all these muscles or whatever muscle fibers you have left. They contract. So the idea is you put these wires in and you put a generator close to it. The wires connect to it, and this generator can last up to 8 to 10 years with battery, right?
Mm.
And it goes on automatically. Well, you turn it on, but 30 minutes in the morning and 30 minutes at night, you sit there or whatever you got to do, and it contracts the muscles for 30 minutes. And it's like a massage, they say. I've never had it done to myself, but they say it's like a massage. You feel a massage and it feels good, they say.
Mm.
For 30 minutes in the morning, 30 minutes at night. And they've showed me pictures of how the muscles were atrophied. It was all white, and it fills in with nice red, thick, strong muscles.
Mm.
And the muscle from the pain coming from atrophy of the muscles go away. Very simple procedure.
Yeah.
And they say that once the muscles are built up, you can turn off the machine. You don't have to use it anymore. Plus, it could stay there. You could take it out, but they recommend putting it in there because the person in itself, they got to that point, sir. Why? Because they don't exercise and they sit around and they don't do much. So it's only going to come back. So what do? You turn it back on, or you just maintain.
Right.
You can maintain it. That right there is an invention that I'm in the process of doing the first ones now. And you know me, I'm always skeptical.
Yeah.
I've read the studies, I've seen the testimonials, and it's promising. And what's the worst that could happen? Providing there's no complications. It doesn't work. And that's another beautiful thing about these procedures. It's not like you're going in there and doing some major surgery and then the patient gets worse.
Right.
I mean, listen, no matter what you do, you can have a complication. But providing you don't have a complication, which is very low from anything we do,
Mm.
anything we do, if there's a high complication rate, we don't do it. The FDA will never have passed it to begin with.
Right.
And if it was like that, it'd be like a lemon law, like a bad car. They take it back.
Yeah.
And they fix it. But it doesn't happen because by the time it gets to my table, in my office, it's tried and true.
Yeah.
The old days, like 20 years ago, the olden days, there was a lot of procedures that I was one of the first people that did them on patients, on live human beings.
It's the pioneer here,
because
ladies
somebody
and gentlemen.
had to do it.
Yeah.
But you have to make it perfectly clear to the patient that this is an experimental and we're doing tests on it.
Right.
But usually, even if it's that, they've proven that it works, in animals and stuff like that.
Right.
All right. So that's what else did I talk about? When I modic changes, we talked about, which is a vertebral by SI joint, facet joint, spondylosis, and we talked about that. But that's been around for 25 years. I've been doing that.
Right.
However, when you treat spinal stenosis, the idea of treating spinal stenosis, and we've been through this, is people, when they sit down, they feel better because this opens up. And when you stand up, this collapses. And I don't, right now, I'm not going to get involved with, why, because of the leather belt, pulling and snapping it.
Yeah.
People, if they could, anybody watch me knows what that is. But simple, it's simple enough. You sit down, opens up, feels good. You stand up, it collapses, no good, right? And by the way, also sciatica pain. You see that nerve? If you put we put spacers in it to keep it up. When you open this up, look at the hole gets bigger. The hole gets bigger and relieves the pressure on the nerve.
Yeah.
We've had some people where at 5S1 especially, they don't have this spinous process to put a spacer in. It's just a nub. But what I've been doing now is I've been putting these facet screws in, which goes into these joints here. And when they go into the joint, watch what it does. It just opens it up just enough to get rid of the pressure along the nerves.
Yeah.
And even the spinal stenosis, sometimes you don't need much to get rid of the pain from spinal stenosis. And it just opens up. I had quite a few patients recently that I've been putting these screws in at 5S1 with patients with numbness and tingling and pain in the feet.
Yeah.
It goes away. The worst one I had was a guy yesterday who it completely went away on his right foot and his left foot. Pain went away, but still has a little bit numbing, intermittent. So what I said to the patient, which I hope, is that might go away, that the pressure's off. And another thing is, we open it up because the epidurals weren't working. Sometimes we open up just that little bit, and all of a sudden the epidurals start to work. And I always tell them, my famous line is, if we have to do an epidural once every 6 months, once a year, it's the best scenario to avoid any kind of major surgery.
Yeah.
So that's.
I thought I saw. I was just looking for it to see if I could find it again, but I saw it was a spacer, and it looked like it had like a pin in the center, almost like a hinge. You know what I'm trying to say? It was weird. I thought it was so
Where'd you see that?
interesting. I don't know. Swiping through and stuff, but you don't know what's AI and what's not anymore.
Well, let me ask you: do I do it?
You don't do it. So
Something
yeah,
it's not worth even
worth it. Yeah.
Don't even bring it up.
Yeah. So yeah, I've been talking to so many happy patients.
Yeah.
It's crazy. One woman was standing in the hallway, and she was looking up at the news articles about your dad and all that, and she was reading them, and then I says, you're looking at Phil there? And she says, oh, says, that's his dad, and I said, and he was an amazing man. I says, but he told Doc to go to Italy to become a doctor, and
he
all
didn't
that.
tell me to go, because anytime
If
my
you're gonna
father
be,
told me to do something, I didn't listen. So I can tell you right off the bat, he didn't tell me anything.
Right, right. Well, you know, and she said, "Oh, he went to Italy, did he? Oh, you know, so yeah." And they don't teach you like to make you specialize in any one thing. You got to know everything. You know. She's, "Oh my gosh, yeah, Doc's a genius."
You know what else is on that wall?
What's that?
My grandfather.
Your grandfather? Yeah, yeah,
My
yeah, yeah.
grandfather. He's on that wall. There's an article on there where there's an article on there that they wrote up probably in the 50s
Hmm.
about a child was born with no anal sphincter.
Wow.
It was like he was born with no asshole, basically.
Right.
And parents, of course, realized it right away
Sure.
and had no way to poop, basically.
Oh my God.
And I'm sure over the years they had different, stuff like that coming out, but not much. And he was one of the first doctors that actually created a new sphincter for the baby.
That's amazing.
And that was my grandfather.
There was another story you told me
About the penis.
Yeah, about the penis.
Yeah.
Yeah.
That was a story we brought up here. That there was a worker that I worked at a machine shop and got his pants caught and ripped his penis right off. But they grabbed it and they put it on ice and they came to my grandfather's office.
Yeah.
They came to his office. Like knocking on the door, ringing the doorbell, and the guy was there with his wife with his penis in his hand. He brought him in, and he had his own little operating room in his office. Right, he lived upstairs, and that was his office downstairs.
That's great.
And by himself, he did like microsurgery. They had the glasses with the loops, no microscope, but they call it microsurgery today because you use a microscope.
Sure.
But he did it, and for years later, they just got married. They had children, had like 4 or 5 kids, and they would write letters to him, and there's pictures of him with the kids and all kinds of stuff. But I mean, nobody did that in those
nobody
days.
did that.
He just knew how to do it, I guess.
Yeah,
with his experience.
I mean, he was probably figuring things out as he went too. This is a family of pioneers, ladies and gentlemen. It's and I was actually telling her about you had a whole family of doctors.
I remember when I was a kid in his office. He says, "I'm going to retire." I said, "Why are you going to retire?" He goes, "Because I can't take it. You got this, the state medical society up your ass, constantly trying to crucify you for stuff. You got the insurance companies that don't want to pay. You got the patients that want to sue you. It's getting worse and worse and worse and worse." I mean, it used to be good in those days compared to today.
Yeah.
They didn't have the litigation those days they do today. It was starting. It was just starting. That's why he wanted to get out. I said, "But no, you've been working for 50 years, and the knowledge that you have put into your brain, and the experience, there's no dollar over that. I mean, you can never compare that to anybody. Even the people coming out today. Well, when I said those days, the new doctors don't know what you know. You teach them because of all experience. Why would you do that? That's almost like a sin. I mean, you should be feel obligated to just keep helping people.
Yeah.
But you get to the point where that's how you feel.
What age was he when he finally stopped?
I think just before 80.
80.
80, because he didn't die too much after 80. He probably died at 83, something like that.
And your dad?
My father retired at 82 or 83.
Yeah. Maggie actually called me this week. She was talking about your dad at the physical therapy place. Well, she wanted to know just how long you specialists, take to before they retire. And I said, well, she says, so how long did Dr. Jasper's father? I said, oh, he was in his 80s when he finally. But that's the kind of people they were.
Yeah.
You didn't stop because your patients meant more to you than nearly almost anything.
And plus we enjoy it.
Yeah.
Like, I really enjoy my job because of the fact that it's just so rewarding. Especially today with all the patients that come in, they just feel better and better and better.
Yeah.
Every time you do something on them, they get better and better.
And with all of these new innovations, I mean, you're just getting more patients in that are going to feel better and better and better.
And you know what? the patients become family because it's not like you give them one shot and they're gone and 100% pain free, or one shot and they go for surgery. No, I mean, these patients become close to us because there's always something that we can do to get rid of that particular pain generator.
Yeah.
And I got patients come in and say, Doc, all right, I'm 80% better. Can you make me better? I said, well, let's go back to the drawing board. And we
Yeah.
look, and there's something that makes them better. And we do it, and they're better.
Right.
So it's amazing.
And sometimes you got to come in for a tune-up, like I do.
Yeah.
I had not too long ago 2 radio frequency ablations, and now I'm right as rain. I mean, there you go. There's my testimonial for radio frequency ablation. That's one of those magic
How
procedures.
often you get it?
Oh, it's like maybe a year and a half, maybe more, 2 years.
See, what they say is, you keep constantly burning the nerve.
Mm-hmm.
And when you burn the nerve, it doesn't come back as fast. Sometimes it never comes back. And when it does come back, it's not as bad.
Yeah.
So that's one thing good about it.
Hey, Felix. Felix says nice T-shirt.
There's another, I knew I forgot something.
Mm.
There's another one now that's relatively new, for me at least, is what we do is if you got nerve pain, you have specific nerve pain, which will, no way you get rid of the pain. What they do is similar to those electrodes that I talked about for the muscle, similar to the electrodes that they do for a spinal cord stimulator, and it's got a generator. We actually put these electrodes, which are wires, right, along the nerve, close to the nerve, and we stimulate the nerve with a special frequency, and it stops the pain. It stops the pain, and then basically what they say is it burns it out, right, by keeping it calm, not painful. This is a temporary thing. It's only 60 days. Right. After 60 days, you pull it out. Patients usually feel great. And if you have to, in the future, if it comes back, you can put it in again for 60 days. And it's all external. This is another thing that people don't like to have implants put in you. It's external. They cover it with special covering where you can take showers. It's as if it's not there. I mean, you feel it's not, but it's constantly stimulates this nerve. Like somebody who has a bad knee that can't have knee surgery, you could do that. People who have like inguinal hernia repairs, you put that in and along the nerve, and it gets rid of the pain in their groin that's caused by maybe an entrapment of the nerve while they did the operation. Or people with low back pain where you can't get rid of it with any of the things that we talked about today, right? And there's nerves in the back that you put these wires in, and the wires go in where they're supposed to be. They come out of the skin, and you cover them up with the generator. 60 days. It works tremendous on getting rid of low back pain.
Yeah.
So, I mean, if there's people out there that has had everything done, but they still have low back pain, we just stick these wires in 60 days, and there's a very high success rate on getting rid of that pain.
Yeah.
And these things take maybe 10 minutes or less to put in. And relatively, you don't even have to go to sleep.
And you control it with your like phone or something,
They got a control.
You can dial it up, dial it down, depending upon your pain level.
Yeah.
Not too bad. Well, we got a couple minutes left. Next week is Thanksgiving. You doing anything special?
Well, not really. Josie was going to have a like the last hurrah at her house, but she sold the house, so that's the end of that.
That's the end of that.
But we're going to spend the day with her tomorrow.
Oh, that's cool.
Help her clean out the house.
Yeah.
I don't know. We're probably going to have. Well, my kitchen's being done, so forget it. We can't do anything in there.
Oh yeah.
So maybe we'll go out to dinner.
That's nice.
Or maybe get some frozen turkey meals. Frozen Thanksgiving meals. Stick it in the microwave. We can sit out in the cold porch with our coats on or something.
go to a Chinese restaurant on Thanksgiving.
Chinese restaurant have turkey. Yeah.
So I'm gonna be away next weekend. Myself, we're gonna be dropping off Benjamin to school. It's my first time going to Harvard, so I'm kind of excited.
Which town is that in?
It's Boston.
Oh, that's right. That's the one we teach at.
Yeah, yeah.
Taught there how to do endoscopic surgery.
Right now he's in Connecticut because it is Boston versus Yale, or sorry, Harvard versus Yale. So he's watching the game, and Maggie will be on her way to pick him up from it. And we got one more thing here. We got Brenda Starr. She loves us. She loves you. She says, "Hi, Doc. Linda
Hey,
from
Brenda.
Lowe's." Now, is she the lady that recognized you by your voice alone? Remember that one time you told me that story?
That's Linda.
Yeah, Linda.
Why'd you say Brenda?
Oh, that's her nom de plume.
Oh, all right.
Yeah.
Linda, how you doing? Yeah. He goes, I recognize your voice. From where? The radio. You're Dr. Jasper. Yeah, that was good.
Yeah.
We straightened her out, but she needs a tune-up. Linda, I know you need a tune-up. Come on in, we'll tune you up.
Tune you up.
Make you feel good.
Yeah.
All right, good. So Felix, didn't you get me this Jasper aviation shirt? I think Felix gave me this shirt.
Yeah, yeah. It's great. It's great looking. But
yeah, right. You know, I've been officially now. I got my last rating that I think I'm going to get for flying an airplane. I have a twin engine. I've been rated now twin engine instrument flying. So technically, I could fly in this kind of weather today. Will I? Probably not.
Probably not.
You know, I mean, it's not like I've been flying since 1987, but I haven't been flying in this stuff. I've been visual flight rules, fly only in good weather.
Yeah.
I will not take any chances. You know what I mean?
You can't.
At this stage of my life, I just, you know, God forbid I get inadvertently go into a cloud or something. I can handle it. Right now, I got to have my own personal minimums. Like sometimes with really good instruments, which I have, and with the way the approaches are today to come in and landing, you can break out of a cloud at 200 feet off the ground.
Right.
Do you realize how low that is, 200 feet off the ground? And look, as soon as you come out of the clouds, the runway should be right in front of you.
Right.
I've simulated that where they put something over you and you got a safety pilot or the instructor and you're following the glide path down or glide slope and they say, okay, you reach minimums, look, and it's right there. So technically I can do it. Am I going to do it? No. I'm not a professional pilot. I got no reason to do that. Let me finish.
Yeah.
I got no reason to do that. However, I will probably do some approaches, go places where it's safe. And my personal minimum is probably going to be more than 1,000 feet. You know, if I don't come out of the clouds at 1,000 feet, I'm going somewhere else. I'm not, and most of those you can come down to 200 feet. You come down to 200 feet, all you got to do is make one little error, and you're pancake.
Right.
I don't feel like I really don't feel like, you know, even though you're pancake, you're dead. But I don't even want to experience that 30 seconds before you get killed. You know what I mean? I don't want to experience that. Right, but I can avoid it. You know what I mean? Yeah, I can try to avoid it.
What's the highest you go?
Well, my plane can go 25,000 feet.
Oh, wow.
And we have it's pressurized, and we got oxygen.
So when you say that, 200 feet don't sound so
well
big from us on the ground, you know?
Yeah. Well, what's good about it is that when you can go up high like that, most of the time you're above all the weather. You're above about 90 plus % out of the weather. Right. You know, those big thunderstorms that you see, right? They can go up to 40, 50, 60,000 feet. But it's not like 40, 50,000 feet for 500 to 1,000 miles.
Right.
It's just they pop up. They're like anvils, and you see them. So when you're above the clouds, you can see them from hundreds of miles away. You avoid them. Legally, you have to be, safely and legally, you have to be 20 miles away from any kind of thunderstorm. But those are the things that kill you, the thunderstorms.
You say anvil as a description. That was very interesting.
Well, you know why? Because that's what it looks like.
Yeah.
Looks like an anvil. That's actually terminology of a cloud. When it's, it's an anvil cloud, which is a nimbus cumulus cloud that is they have updrafts.
Yeah, no, that's
See,
great.
what causes it? The updrafts causes all the bad weather,
Right.
right? And when it goes up, it reaches an atmosphere where it's where a dew point temperature, and it just won't go above that. So what happens? It pushes and smashes, and it's flat on top because it doesn't. The clouds, clouds go only. You could estimate almost precisely exactly how high the clouds are based on the atmospheric pressure, based on the temperature. The dew point is a calculation. Don't ask me what that is right now, but if you do that calculation based on the weather forecast, you know how high those clouds are.
So you have an encyclopedic memory about medicine, and now
Well, I mean,
I
listen.
mean, I told that woman again, going back to her, I said, it always shocks me the amount of information that's in his head. I said, he knows things that the rest of us would have forgotten, or terms. I don't know, how the frick does he keep all of that in his head, and he just pops it off as if it was nothing?
Well, you know what it is. My father told me when I was a kid. I
Yeah.
said, Dad, I don't know how I can fit all this in my brain. You know what he said? He goes, son, the brain is an endless reservoir.
Oh,
He says, you can never fill up your brain with information. A reservoir gets to a certain point and it overflows.
right.
Your brain will never overflow. It's an endless reservoir of information. Sometimes you have trouble retrieving it.
Yeah. Yeah.
You have trouble retrieving it.
Right.
And then when you get too old, I guess the synapses and all that stuff, they're not as good.
Right.
But as long as you got your wits there, it's there. You can find it. And usually it's all based on correlation. You got to correlate certain things with the actual memory.
Yeah.
And then you don't forget it.
All right.
All right. Well, thank you very much, everybody, for whoever joined us. How many people joined us? Oh, yeah, 3 people. That's good. Thank you, audience. No, is there any way we could tell who joined us? How many?
Yeah, well, we got Linda, Felix, and then
No, I'm talking about overall. I mean,
overall we were bouncing from 3 to 4 live, but that'll be like maybe 150 by the end of the day. By the end of next week, it'll be 400 and 500, something like that.
well, I'll tell you what, there were like 600 people that viewed something that was a testimonial that wasn't even too long ago.
Yeah.
We got to call. If anybody's watching our testimony, there's a lady in there that talked about how we put gel or something or stem cells in her back. It wasn't stem cells. It was this via disc, which is the allograft of the nucleus we talked about today.
Yeah.
To regenerate.
I'll show her to one of the nurses and see if we can track her down and ask her to come back in to do a more.
All the Jasper kids know too much.
It's Carmel.
Too much. Is that a negative? Probably negative.
Yeah.
All right, Carmel. Hey, listen, you coming to Josie's house tomorrow with us? All right.
All right.
Have a great Thanksgiving if I don't talk to you guys or see anybody. And thank you very much for everything.
For more information about Dr. Gabriel Jasper, please go to jaspermd.com. You can make an appointment by dialing 732-262-0700. And the Jasper Spine Institute is located at 74 Brick Boulevard, Brick, New Jersey.